Welcome, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Dr. Nik London from San Diego. And we're going to talk about antisense therapy for geographic atrophy. It's an exciting conceptual departure from our current thinking about how geographic atrophy might be treated. Nik, welcome to Retina Synthesis.
Great. Thank you so much, Carmen. It's really a privilege to be here and great to see you again.
So tell us a little bit about what antisense therapy is.
So antisense therapy is a unique approach to treating diseases, and there are several FDA-approved antisense treatments. I think there are about 18 or so that are now approved. And Ionis, which is the company behind the Golden Study, which we'll be discussing a little bit, I think it's sort of a leader in that field in the antisense oligonucleotide space, and it has 3 of those FDA-approved drugs, I believe. Antisense oligonucleotides are little strands of nucleotides that actually will degrade the mRNA strand and inhibit protein synthesis. So it actually stops the problem before the problem occurs, before the proteins are produced, which is different than what we usually do. We currently have monoclonal antibodies, receptor decoys that will try to target the protein following production. So, I kind of ingest a little bit, think of this like, Arnold Schwarzenegger in The Terminator, where he goes back to kill John Connor before John Connor is even born to prevent things from even happening.
So that's it's a single strand of DNA. Is that right?
That's right. It's a strand of nucleotides.
Exactly. Right, and it inhibits messenger RNA from the mutated gene.
Yeah, it actually it'll bind to the messenger RNA, and then it will recruit an RNase H1, which will then degrade. In this case, at least, degrade the messenger RNA strand, therefore inhibiting the production of the protein.
So how is the drug delivered?
So in this case, it's subcutaneous, which in most of my patients that are in the trial is in the abdomen. It can also be given in the thigh, but it's a pretty easy injection. Patients don't mind at all. You simply pinch, an inch or so of abdominal tissue, and it's a tiny little needle, give it a little volume of injection, and they're gone. So it's pretty well tolerated.
How frequently were the injections in the study?
Monthly injections.
So what molecular pathway are we targeting?
So we're trying to inhibit factor B production. So the drug is once you inject it subcutaneous, it rapidly enters the bloodstream, goes to the liver where it's taken up by hepatocytes, which is where most of the factor B is produced. And in the hepatocytes, it inhibits the production of factor B through the mechanism we just talked about.
So, and the evidence for factor B's relevance to macular degeneration is from genetic association studies?
Yeah, we know that the complement system is involved. We've got a lot of evidence that complement activity is implicated in the pathogenesis of GA. We know complement is deposited in drusen. We know that complement inhibitors, we've got 2 complement inhibitors that are hopefully on the brink of FDA approval. And we also have genetic studies, as you mentioned, so several genetic defects in the complement pathway. This drug inhibits factor B, which is part of the alternative pathway, which is we believe is the most implicated in GA progression.
So what's the evidence from the phase 1 trials that this approach is safe and elevates and suppresses factor B levels?
Yeah, so a lot of the data are actually, we have some preclinical studies. So prior to the phase 1, they looked at monkey studies, and they did, I believe, weekly injections with essentially the same drug, and looked at both systemic and ocular factor B levels and showed a very dramatic reduction in factor B production, which really indicates that the majority of ocular factor B is derived from the liver, since we know this drug is acting at the level of the liver. The phase 1 study was done several years ago in healthy volunteers. So these were patients without disease. And there were sort of two phases. There were a single ascending dose stage where they looked at 3 different doses of the medication given every 3 weeks. And then a multiple ascending dose phase where they gave the injection every 2 weeks and then every 4 weeks. In those studies, you saw plasma concentrations after a single injection would dramatically decline. So plasma concentrations of factor B. The drug was fairly rapidly cleared from the plasma, but stayed in the liver. Hepatic levels were there for quite a long time, which is what led into the phase 2 study design of every 4-week dosing. And multiple doses demonstrated a pretty significant dose-dependent reduction in plasma factor B compared to placebo.
So
maybe, I don't know if we can incorporate the slides at some point into the podcast, but we can show that if possible.
So let's discuss the design of the phase 2 trial. When did it get started, by the way?
When did it get started?
Yes.
Oh, I don't know. We've been involved in it for well over a year. It's been sort of slow to recruit for. It has a relatively high screen fail rate, usually the size of the lesion, and previously fellow eye CNVM, which of note is now allowed. But I'd say we've been involved for about a year and a half.
Mm-hmm.
In this
Is
study.
enrollment near completion?
No, let me see if I have the enrollment here. No, it's I think that they still are, I would guess, around 50% enrollment, but I don't know that number.
So let's talk about the design of the study. What are the entry criteria?
So the inclusion exclusion criteria are age over 50, sort of your typical GA patient, BCVA better than 2200, and the lesion size about 2 to 17 disc areas. The key exclusion criteria would be a history of a CNVM in the study eye, but fellow eye is actually allowed, which is a little bit unique. They also exclude patients with a history of immune suppression or immune deficiency because this is a systemic complement inhibitor. The primary endpoint of the phase 2 study is the change in the size of the GA lesion from baseline to 1 year. And key secondary endpoints are sort of common for our GA studies: low luminance visual acuity, change in plasma factor B levels, as well as the change in serum alternative complement pathway activity. There were 2 stages to the phase 2 study. The first stage looked at 3 doses of the drug, the Ionis factor B drug, compared to placebo, at which point they did at 3 months, they did an interim analysis and decided to proceed with 2 of those dose levels in the second stage of the phase 2 study. And that's the phase that's recruiting now. Its target is to have about 270 patients in the stage 2 with, again, the 12-month primary endpoint. And patients are going to be receiving monthly doses of the subcutaneous medication compared to placebo.
Of course, the fellow eye is being treated as well.
That's one of the benefits of this. When I talk to my patients about the options, and we have about 3 or 4 GA studies that are currently enrolling, one of the big benefits of this study is that both eyes will be treated if you have GA in both eyes. We also, there's some theoretical evidence that this might help if they have intermediate AMD. It might lower the risk of progression, GA, or CNVM development for people with high-risk intermediate AMD. The other benefit to patients is, again, that it's not an eye injection or surgical treatment. So that's attractive to a lot of patients.
So how is factor B inhibition different than blocking C3?
Yeah, that's a great question. So I don't know. The one thing that I've been told, they both are going to be involved in the alternative complement pathway pretty strictly. The factor B inhibition, we think, will preserve much of the other pathways, the classical pathway and the lectin pathway. We also believe that factor B is involved in something called the amplification loop. So if we can inhibit factor B, we may inhibit that amplification loop.
So where do you think this is going to go?
I think it's going to work. I hope it works. Our patients sort of, as you well know, as everybody listening well knows, we've got a lot of patients with GA where we can do nothing, and we need to have something effective. Again, we've got 2 drugs on the brink of approval, but having multiple options, who knows if we're going to be able to have combination therapy with these different options to do more than just a 20% or so reduction in GA progression, as well as to give patients an option of something that isn't an eye injection and treats both eyes in one dose. So I don't know where it's going to go. That's why we're doing the phase 2 trial. I hope it's effective, and I hope it leads into a phase 3 large trial. But time will tell.
Great. Well, Nik, thanks so much for sharing your knowledge about antisense therapy for geographic atrophy.
You're
very
welcome.
Interesting.
Great.
We'll have you back after the phase 2 results are released.
I'd love to. Thanks so much.
Thank you.